I think we're good to go ahead and get started. So my name is Jess Onikian from Focal One, and I'm pleased to be a part of tonight's virtual event. The goal of tonight's presentation is for educational purposes. Again, we're fortunate to be hearing from Dr. Gopal Gupta from Gottlieb Memorial Hospital in Melrose Park, Illinois, as he discusses the diagnosis and treatment option of prostate cancer and robotic focal HIFU, a non-surgical, non-invasive, high-intensity focused ultrasound that urologists use to precisely target the disease portion of the prostate. As questions arise during the presentation, please utilize the Q&A button located on the bottom of your screen. We'll have time after the presentation to answer the questions that are asked within the chat. So let me begin by introducing you to tonight's presenter, Dr. Gupta. Dr. Gupta practices the breadth of urologic oncology at Loyola Medicine in the Chicagoland area. Dr. Gupta received his BS in biological chemistry from the University of Chicago in 1996 and received his Doctor of Medicine from the University of Illinois at Chicago in 2002. He then performed his residency in urologic surgery at the University of Maryland Medical Center. He then continued his training as a fellow in urologic oncology at the National Cancer Institute in the Urologic Oncology branch under the guidance of Dr. W. Marston Linehan. In 2011, he was recruited to the Department of Urology by Dr. Robert Flanagan as a fellowship-trained urologic oncologist. Dr. Gupta holds a primary appointment in the Department of Urology and has a joint appointment in the Department of Surgery and the Oncology Institute. His primary clinical research interests pertain to bladder, kidney, and prostate cancer. Dr. Gupta performs minimally invasive surgeries using the Da Vinci robotic surgery platform, and his clinical interests are to push the cutting edge of technology while optimizing cancer outcomes. He is also interested in the role of targeted therapies either before or after surgery to enhance cancer outcomes. Dr. Gupta's laboratory is located in the Oncology Institute and has been named a Dean's Office clinical scholar and splits his time between clinical responsibilities and his clinical research interests. Under the guidance of world experts, Dr. Gupta developed expertise in a multitude of minimally invasive techniques to treat urologic cancers. He is well-versed in robotic-assisted surgeries and is enthusiastic to further the access of the newest techniques to treat prostate cancer, such as HIFU. Without further ado, welcome Dr. Gupta, and thank you for being with us tonight. The floor is yours.
Thank you, Jessica. Thank you, everyone, for spending the next 20 to 25 minutes with me this evening. I know, given the time slot, I'm going to be the main roadblock between you and dinner. But I am very excited to talk to you about a new treatment option in prostate cancer that we're now offering at Loyola Medicine. And this is what we call robotic focal HIFU. So let me just advance the slides. I have no relevant disclosures. So our agenda tonight, we'll just review some facts about prostate cancer. We'll review the importance of prostate cancer screening. We'll just highlight the treatment options. We'll discuss HIFU. We'll discuss the advantages. Who's a good candidate for HIFU? What is treatment like? What happens after treatment? I have a short slide on some clinical data, and then I'd like to open it up to your questions. So prostate cancer is the most common cancer of men in the United States and pretty much worldwide. You could see that in the top right. So there are about 288,000 cases diagnosed in the United States every year. 34,000 men die of this disease. And we're biopsying about 1 million people to detect prostate cancer. So this is a really prevalent cancer. We use PSA blood test. This is a protein that is produced by the tissue in the prostate. This blood test is used to primarily screen for prostate cancer. It can detect it's correlated, the levels are correlated to the risk of cancer. But there are a lot of other things that could be going on in the prostate or around that could cause an elevated PSA that are not cancer. So the best advice is to really talk to your primary care physician about undergoing PSA screening. It is recommended by most guidelines, especially the American Cancer Society, the American Urologic Association. And as most people can understand, early detection of prostate cancer is critical in getting good outcomes. So the American Urologic recommends getting a baseline PSA test at age 40 if you are high risk, African American race, or have a family member, otherwise at 45. And then in consultation with your urologist, you'll figure out a PSA testing interval. So let's say your PSA is elevated. What are the next steps? Typically, and at Loyola Medicine, we recommend you undergo a prostate MRI. Now, this is a really important study. It allows us to get accurate, detailed pictures of the prostate, and it allows us to prognosticate if cancer is there. It also allows us to obtain tissue if you undergo a prostate biopsy. And this really improves the accuracy of cancer detection, and it really helps risk stratify what therapies are available if, in fact, cancer is detected. I just want to review our team at Loyola was the first in Illinois to offer MRI ultrasound fusion biopsy. So a man undergoes PSA screening, has an elevated PSA, would be recommended to undergo an MRI. And the MRI might suggest an area of cancer, and we're able to put needles into that area and really rule out or rule in the prostate cancer and really get a sense of how aggressive. This really revolutionized prostate cancer diagnosis. This is a representative picture of a man's prostate. And if you kind of squint your eye, and of course, we're cheating a little bit with the arrow test, but that dark area is the opposite, the mirror image of the light area, which is normal. And if you squint your eyes, you can tell that that's an abnormal area. And the MRI is really the only imaging test that can accurately lead us to the areas of cancer. I mentioned that at Loyola Medicine, we were the first to perform this MRI-guided biopsy, and this is what it looks like. The MRI is overlaid in red on the ultrasound image that's real time. And it's really a bullseye comes up from where the radiologist says the area of interest is. And we are within a couple millimeters able to place a needle into that area to then submit that tissue for pathologic diagnosis. Is it cancer? Is it not? So it adds a lot getting an MRI. So this is someone's prostate. Based on the MRI, we have a very accurate volume. You can see the prostate is in red. And more importantly, you can see the area of cancer that was biopsied in yellow. And that tells us a lot of information. Where in the prostate is this? What is the relationship to the surrounding organs? How big is that cancerous area? Are there any other signs of advanced cancer? Like, is the cancer spreading outside of the prostate gland? Is it invading into the adjacent structures? And we need to know this because we need to align the man with the right treatment option. And in this case, that area was cancerous. So we also, you may have heard that prostate biopsies are no fun. I've never had a man say, I enjoyed that. And rightly so. For the long time, we've been doing prostate biopsies by inserting an ultrasound in the rectum, giving local numbing medicine, and then advancing the needle through the rectal wall into the prostate. That was called a transrectal biopsy. We stopped doing those in 2019 because of the higher infection rate. I mean, there's stool in the colon and also from rectal bleeding and discomfort. We're now offering transperineal biopsies. This is where the ultrasound is in the rectum, but the needle does not violate the rectal wall. It goes in through the skin right above the anus called the perineum. And if you'd like to learn more throughout this seminar, you'll see the 2D barcode, similar to what restaurants switched to during the pandemic. And if you hold your phone up to that 2D barcode, it should suggest the link so you can look at these videos or you can look at the data or the resource yourself later on. So here's just a picture of the transperineal versus the transrectal biopsy. And it just summarizes what I said. The needle does not go through the rectal wall. It eliminates rectal bleeding. It eliminates colonization of stool and fecal bacteria into the prostate. It's well tolerated. We're offering these with nitrous oxide now in the office and with mild sedation like a colonoscopy for those who prefer that. So I had this slide from a talk I gave a long time ago, and we were just talking about what is the future of prostate cancer treatment. So now we can see the area of cancer in the prostate. We biopsied the area of cancer. We know its aggressiveness. We know its size. We know its relationship to the surrounding tissues and organs. Could we, in the future, perform focal therapy? Instead of treating the entire prostate gland, could we just treat the area of cancer? And I'm pleased to tell you that this era of focal therapy has arrived. And HIFU represents one option that is a targeted therapy. So this really kind of is a good summary of how to think about this. Currently, for prostate cancer, we're employing radical surgery or whole gland treatment. So in the bottom, we used to perform prostate removal through an open incision. I now do 100% of my robotic prostate removals robotically. And now with this idea of HIFU or other targeted therapies, you can treat potentially the tumor only and spare the entire organ. Now, above this, this is not a radical thought. This is being performed in breast cancer. Instead of removing the whole breast, they can remove the area of tumor called a lumpectomy in certain cases. So this focal therapy will fill an important treatment gap for men who are diagnosed with prostate cancer. It's not for everyone, but it is for the carefully selected patient with the appropriate cancer type. And we'll go over some of the criteria, but really low risk, intermediate risk for now. Maybe the future will allow for different categories of men to have focal therapy. And also it's being used when a man has radiation therapy and the prostate cancer comes back in the prostate and could be potentially ablated. So what is HIFU? It stands for High Intensity Focused Ultrasound. And what this means is really there's no surgery, there's no cutting, there's no radiation. I like to describe this as when we were children, you would have a magnifying glass and you would take the sun's rays, and if you concentrated them, you could actually burn a leaf or you could burn paper. And what this is doing is it's taking ultrasound energy, it's focusing it, and it's able to burn tissue at the end of its focal point. So it avoids burning what's in front of it, but you can concentrate it much like the magnifying glass analogy. And what this is doing is if we can see the cancer, we can apply this high intensity focused ultrasound energy to the area of cancer and to a rim of healthy tissue around the cancer to make sure that it's fully ablated. And this could really minimize some of the side effects of radical therapy. And the most common ones are the risk of surgery, the risk of radiation, long-term risk of radiation, incontinence, and erectile dysfunction. So again, I got ahead of myself, but some of the advantages of a HIFU, it's non-invasive. There's no incision, there's no blade, no scar, no radiations involved. It's really well tolerated. You're back on your feet roughly a week to 10 days after the procedure. It's outpatient. You get to go home the same day. And the side effects are less. I mean, there are side effects, and we'll discuss this, but they're much less than radical treatments like robotic prostatectomy or forms of radiation. Here's some data. that's been collated from multiple institutions. We call this pooled data, but what it is showing is that it's comparing doing nothing, active surveillance, to focal HIFU, to the radical therapies of radiotherapy and radical prostatectomy. And overall, what you can take away from this is that the rate of incontinence or leaking is very low. It's almost the same as the group where we're doing no intervention. Erectile dysfunction is also roughly the same as active surveillance, much lower than radiotherapy and radical prostatectomy. The same with bowel dysfunction, which makes sense. Urinary stricture, that's blockage of the urethra, does occur, but it's less than radiation. And ejaculation, that's the fancy word for when you climax and you don't see semen. So that's much less than the radical therapies. So patient selection, who's eligible? That's the million-dollar question. Currently, this is a very case-by-case basis. We have to see what your prostate gland looks like, what grade cancer. So these are grade groups or Gleason grades if you've had cancer or are familiar with it. And really, right now, we're doing careful selection of patients who are in the low to intermediate grade cancers. There's a lot of considerations. Patient size, weight, where is the cancer located? As I mentioned, are there any other history of procedures? And there's also some disqualifying things that might be present, like calcifications in the prostate, because the HIFU can't penetrate those calcifications, and some other considerations. So what to expect on the day of your HIFU procedure? You arrive the morning of the treatment. You have completed a bowel prep and have had nothing to eat or drink the night before. The procedure is administered with general anesthesia. It's important that you are not moving during the procedure because it would affect the accuracy. So the anesthesiologist will take good care of you. The treating urologist, myself, will perform the HIFU system. We'll operate it in such a way that we are only going to apply the HIFU energy to the area of cancer that we've seen on the MRI, and we'll locate it again the day of the procedure, and a healthy rim of tissue. The patient is woken up, has minimal pain. A catheter is placed while they're asleep. They'll go to the recovery room. And from there, they'll go back to same-day surgery where they'll meet their family. And once they pass some milestones and we do the teaching on how to take care of the catheter and what to look for, then they're typically safe for discharge. So after the treatment, I mentioned the catheter. It's really not that bad. It's placed while you're asleep. You can make friends with it for 5 to 7 days, I promise you. And then you'll come back to the office, the catheter will be removed, and hopefully you'll have minimal side effects. You may notice a little bit of leakage, which is transient, and some erectile dysfunction that could play out over months. Typical follow-up is at 6 months, we'll follow the PSA test, and we'd like to see it go down. And typically at 1 year, we'll repeat an MRI to see how the ablation looks, and probably recommend a biopsy to make sure that the cancer is gone. So I have one slide with some clinical evidence. This was presented at our International Urology Conference. This is a big study that came out of Europe called the HIFI study. They looked and they did a really good job. They randomized patients. They tried to find similar patients. And they kind of opened the envelope to either radical prostatectomy or HIFU across 46 centers. This study involved a little over 3,000 patients. And basically, if you look, the urinary continence, or the percentage of patients who were leaking after, was better with the HIFU group. And erectile function was less impacted in the HIFU group. And again, this the chart or the graph here is showing that fewer HIFU patients needed to have repeat therapy, or their cancer was comparably controlled as with the radical therapy group. out to 30 months. So in conclusion, HIFU, the procedure itself, there's no scar, there's no blood loss, you avoid radiation. It's a good non-invasive option for well-selected patients. You really got to see your urologist and talk about it. It's a well-tolerated outpatient procedure. I mentioned it fills this treatment gap between active surveillance and radical whole gland therapies like robotic prostatectomy and radiation. It minimizes side effects from the radical therapy, as we talked, and the outcomes so far are good. So you may ask, why HIFU at Loyola? Well, Loyola is a leader in prostate cancer therapy. Myself and my colleagues who are urologic oncologists are very experienced. I mentioned we understand MRI, the role of the transperineal prostate biopsy, and we're now very happy to be able to offer patients HIFU. And again, there's a barcode there. There's a good blog where we summarize this and we have more information. So I'd like to thank you for taking the time to listen to this. If you'd like to learn more, this is a different code you can scan that will take you to our patient information page on HIFU and also allow you to make an online appointment, or you can call the Cardinal Bernardin Cancer Center helpline if you wish to make a consultation. Thank you.
Thank you so much, Dr. Gupta. Thank you for taking us through that extremely informative presentation. We have had a few questions come in through the chat, so if you're cool with it, let's go ahead and address them.
Sure.
The first one that came in was, can you get HIFU if you've gotten radiation done first?
Yes, you can. So that was probably one of the first indications for HIFU, which was in patients who have had radiation therapy and had a recurrence of prostate cancer in the gland. Because, surgery is actually pretty difficult in those patients, and HIFU is an option, along with other focal therapies like cryo and nanoknife.
Thank you for answering that. Another one that came in, someone here is in their mid-80s and is wondering if they can still consider this as a treatment option.
Yeah, age doesn't limit anyone from treatment. So I would encourage them to speak to their urologist about it.
Thank you. Another one that came in, will I need to be on pain medication afterward? If so, for how long?
Great question. Typically, ibuprofen and Tylenol for a couple of days. You don't need narcotics after this. You can drive, even with the catheter. We'll teach you how to do that. You can shower. You're independent. You can dress yourself, eat, drink. So pain control is really with just over-the-counter medications.
Awesome. Thank you for addressing that. I know you said that age isn't really a factor here, but we actually have somebody on the contrary who is asking that, is there an age that is too young for this treatment that I wanted to ask?
Not really. Fortunately, prostate cancer doesn't occur in the very young, but it can happen. And I've seen it, sadly enough, in men who are in their late 40s, early 50s. And the way we're thinking about focal therapy is that this could offer curative intent therapy. And if not, because cancer could come back in a different location, it could come back in the same area, they're still able to have the other radical treatments, definitive treatments.
Thank you, Dr. Gupta. Another question that came in was, will I still need to get biopsies after being treated?
We do that on a case-by-case basis. The nice thing about MRI is we recommend getting an MRI at 1 year after the therapy. If the MRI is suggesting that the tissue looks like it has changes consistent with good success from the ablation, one could potentially not have to have a biopsy. But sometimes it's equivocal. The MRI might be on the fence, or the PSA may not go down. And in those cases, for the patient's benefit, we recommend repeating a biopsy just to know Is there a new area of cancer, or is cancer persisting in that area?
Thank you. And we had one more question come in. How does this treatment impact patients' quality of life versus other treatment options you use?
So if we compare HIFU and other focal therapies to what we call the radical therapies, the ones that are treating the entire prostate gland, which are all the forms of radiation and robotic surgery, the side effects, incontinence, erectile dysfunction, or inability to have or maintain an erection are much less impacted with these focal therapies.
Thank you, Dr. Gupta. Oh, we have another question that came in. Questions keep pouring in here. One other person on this webinar asked, will this help at all with my BPH?
So right now, there's no indication for focal therapy for BPH. And so we're not quite sure. I can't say it would help. I would be worried that it could make those symptoms worse. But that's something that's really individualized, because you might be able to undergo a BPH procedure or medications and then be a candidate for HIFU, but that would be, a very individualized decision.
Awesome. Thanks for addressing that, Dr. Gupta. And I have a few people in this chat asking how they can make an appointment with you. So I just wanted to reiterate what Dr. Gupta said before. Please go ahead and scan the QR code and take down that phone number that you see there on the screen to make an appointment with Dr. Gupta following this. With that, we have addressed actually all of the questions here tonight. So, Dr. Gupta, I just wanted to thank you so much for your time and sharing your insight and expertise with us. I'll reiterate it one more time. If any of you would like to make an appointment, please feel free to save the number that you see here on the screen. And before we close out, Dr. Gupta, is there anything else that you wanted to add?
No, I'd like to thank everyone who came and participated for taking the time out to hear about this and your really insightful questions.
Awesome. Thanks so much, Dr. Gupta, and thank you everybody for joining. Have a good evening.
Thank you.